Deep brain stimulation for Parkinson's disease, an analysis of a neurostimulated device and its treatment of disease.
When people think about Parkinson's disease, they usually think of the classic motor symptoms of movement rigidity, resting tremors, and postural instability. Many people may also associate PD with an old person's disease. However, early onset diagnosis has been found in patients as young as 21, with an overall prevalence of 294 per 100,000 people in Australia alone. The pathology of Parkinson's disease arises as a result of dopaminergic neuron degeneration in the substantia nigra of the nervous system. As such, pharmaceutical medication focuses on maximizing the availability of dopamine in the brain, with levodopa being the gold standard treatment. However, medication-induced dyskinesia, which is uncontrolled involuntary movements of the face, arms and legs, may develop as a complication of long-term medication use. Epidemiological studies have reported the prevalence of dyskinesia in 55% of patients after long-term treatment with levodopa. In such cases where motor symptoms appear to be refractory to pharmaceutical therapy, deep brain stimulation is implemented as a therapeutic option. What exactly is deep brain stimulation? DBS is a neurosurgical procedure that has been approved for the treatment of drug-resistant movement disorders such as Parkinson's disease. DBS systems involve the keyhole insertion of one or more electrical leads into the brain. These electrical leads are then connected to extension wires that are channeled under the skin to a neurostimulator device called an implanted pulse generator, which is typically positioned beneath the collarbone. The electrical impulses emitted by the IPG are signaled to the affected areas of the brain through the implanted electrodes to correct abnormal neural signaling.
The safety of deep brain stimulation can be evaluated by the assessment of potential risks, danger, and injury associated to its treatment. Contraindications include skin erosion, system migration, and tunneling due to nerve or vascular injury, as use of high amplitudes and wide pulse widths are required for stimulation. Associated physical risks due to implant procedure itself include intracranial hemorrhage, cerebral infarction, CSF leakage, seizures, meningitis, cerebral edema, and much more. More mental and psychological risks include new onset or worsening of depression and suicidal ideation. Consequently, such associated risks further increase the potential of clinical conditions including stroke, neurological disorders, cardiovascular disease, renal and hepatic failure, and diabetes mellitus. As deep brain stimulation treatment involves brain surgery and modulation of brain states, ethical issues are constantly arising due to past unethical neurological practices coexisting with current perspectives which show growing concern for the patient's personal identity and public perception. Most research in this area is structured by 4 basic principles of medical ethics: non-maleficence, beneficence, justice, and respect for autonomy. This structure discusses the concerns for balancing risks and benefits of maintaining respect for the autonomous choices of the patient, more specifically safeguarding their rights and interests when in a vulnerable position, psychosocial impact of treatment, as it has been found that the quality of life has decreased in emotional well-being, social support, and interpersonal relationships, as well as the effects of personal and self-identity, which basically refers to although the patient is the same person, there may be effects on bodily and psychological criteria.
Costs are inclusive of physician visits for the assessment of the disease, performance of the surgeries pre, during, and post-operation, and hospital fees. On top of these are the costs of battery replacements every 5 years and additional physician consultations if further surgery is necessary. Deep brain stimulation operation costs approximately around $30,000 in Australia. The Western Australian Health Department have actually subsidised DBS, and hence we can see that although hospitals they may have DBS systems and surgeons available to perform the surgery, many people don't have the funds to access it. With the increase in technological advancements, there have been many researches on how to make the deep brain stimulation devices cost-effective and safer and easier for managing diseases. Cost-effective by creating different prototypes from various materials as cheaper alternatives that can be more beneficial and responsive to treatments, and so that DBS is made more available to patients. And it should also be safer and easier for managing diseases by creating long-lasting batteries, ensuring the electrodes and programming for DBS is set to provide an optimal outcome for the patient so that the implantation does not create further complications.
So who would be a good candidate for deep brain stimulation? Suitable candidates would be people who have epilepsy or movement disorders with moderate to severe symptoms that do not respond to medications. It is important to administer accurate information of the patient, as each surgery is customized for each individual's clinical status. Prior undergoing the surgery, the neurologist would have to run MRI scans and plan a programming session that is personalized for the individual. Manual adjustments of stimulation parameters will be performed. In Parkinson's disease, for example, the electrode is placed near structures like the subthalamic nucleus, and modifying these overexcitable regions can alleviate symptoms of Parkinson's disease.
As mentioned, the high cost of the surgery and device is one of the largest barriers in determining potential DBS candidates. And as DBS is personalised for every patient, frequent visits to specialised centres are required, whether that's for surgery, monitoring, or reprogramming the device. Therefore, a person's ability to receive social and caregiver support and the physical distance between a patient and team are potential barriers to care that can determine the success or failure of DBS.